بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. برحب بحضراتكم في مراجعة في نص الموديول بتاع الهيدن دينيك، وكان في مجرد اقتراح إن الموديولات الطويلة ممكن إن إحنا نبقى نتقابل في نص الموديول كده، نحاول نسترجع بعض المعلومات، وبعدين نتقابل تاني في نهاية الموديول عشان نعمل ريفيجن عام على كل الموديول، وإن شاء الله تكون مفيدة يعني في مصلحتكم بإذن الله تعالى. في نفس الوقت اللي بيكون ذاكر حاجة وعنده أسئلة عاوز يسألها، ما فيش مشكلة إن احنا نجاوب عليها إن شاء الله. هيكون في بنفس الطريقة عبارة عن مجموعة من الحالات، وحضراتكم بتجاوبوا عليها عن طريق الشات، وبيكون في بعض التعقيبات على الحالة وزي ريفيو كده صغير على ال differential diagnosis بتاعها. ودهيت أول and this is the first case, male 33 years old, and he has troubles with breathing, loss of smell, decreased taste, post nasal drip, and running nose. This is coronal CT of the paranasal sinuses. And what do you think about the diagnosis? Yes, and the answer is right. This is an antroconal polyp with almost total opacification of the maxillary sinus, widening of the ostium, and the intrasinus pathology is seen extending through the widened ostium into the nasal cavity, merging with the nasal turbinates. And this is the criteria of the antroconal polyp, including that the ethmoidal air cells on the same side of the antroconal polyp are usually clear. This is not mandatory, but it is a frequent finding that the ethmoidal air cells on the same side of the antroconal polyp is usually clear. This can be differentiated from another similar pathology, which is known as the inverted papilloma. This papilloma is a benign lesion arising inside the nose and may extend inside the antrum, but in such case the antrum is small and the nasal fossa is expanded by the tumor, as well as the ethmoidal air cells on the same side of the lesion are usually opaque. The etiology of this papilloma is not known and is commonly seen in the middle-aged males and present by unilateral nasal obstruction and may extend into the maxillary and ethmoidal sinuses. This is the difference between antroconal polyp with expanded antrum and mass in the nose with clear ethmoidal air cells, and the inverted papilloma with expanded nose, collapsed antrum, and opaque ethmoidal air cells. Many of the investigators in the literature describe this as a pathognomonic criteria, which is known as the convoluted cribriform pattern seen on T2 weighted images, which is similar to the brain tissue, or what looks like a brain tissue inside the nasal fossa as well as inside the maxillary antrum. And this sign is seen in up to 100% of the cases of inverted papilloma, but is uncommon in other sinonasal pathologies. Then the next case is a female patient, 40 years old, and this is CT scan of the orbits. Yes, and this is an intraorbital dermoid cyst on the left side a well-defined cystic lesion with fat fluid level and a bone remodeling adjacent to the cyst, denoting that it is a benign, long-standing condition. And this is the appearance on MRI. On T1 weighted image, the fat is bright and the fluid is dark, while on the fat suppressed images, the fat will be suppressed and the fluid will remain as it is. And the diagnosis is an orbital dermoid cyst. Actually, I provided this list of differential diagnoses considering masses in the orbital fat, meaning that these lesions are not located in the globe, not in the optic nerve, not in the muscles, not in the lacrimal gland. Then you look for the lesion. If it is an ill-defined lesion, consider orbital pseudotumor. If it is a well-defined lesion, look at the enhancement pattern. If there is a homogeneous enhancement, consider first of all is cavernous hemangioma, then neurofibroma and lymphoma. But if it is not enhancing, meaning that it is cystic not enhancing, you consider dermoid first, then you consider epidermoid cyst. And in such a case, you can see that dermoid cyst contains fat, and fat is dark than the fluid in the globe, for example, and it can occur inside the orbit and it can occur at the external or the internal cancers. Many of the lesions, because of slow growth, are associated with scalloping of the adjacent bone as well as sclerosis. Then the next case is also a case of an MRI, CT and MRI of the orbit. And what do you think about the diagnosis? Ocular hemorrhage, this is not the right diagnosis. Um, uh, Retinal detachment is also is not the right diagnosis. And one of the no is not suffices will buy. One of the important findings is the small size of the globe and the bright signal in all birth sequences as well as in the CT. And these features are diagnostic of persistent hyperplastic primary vitreous, and this is the right answer. You see that the globe is small and it's hyperdense in the CT, high signal in T1 and T2, and if you inject contrast enhancement, it will not enhance. Sometimes the lens is deformed and you may got some abnormalities posterior to the lens, but there are two main issues here. Number one is the small size of the globe, and number two is the hyperdensity of the lesion in CT and high signal on MRI with, of course, absence of calcium. And this is very important. Persistent hyperplastic primary vitreous is a congenital pathology due to persistence of the remnants of the hyaloid vessels inside the globe, which is present before the during the fetal life. And these are the important diagnostic findings for persistent hyperplastic primary vitreous. Number one,
هنتبهدل ومش هنتبهدل ومش عارفين حد.
مش سامع حاجة.
وبعدين بتوع العرب كنت بقى عاوز اروح على فين؟ بتاع مصر اروح على العرب.
يا سارة.
يا دكتور مع حضرتك.
اقفلي المايكات بتاعت المستمعين علشان بيتكلموا في حاجات جانبية.
طيب حاضر ماشي ثانية واحدة.
طيب خلينا نكمل في القضية بتاعتنا. واحنا قلنا ان the imaging findings in patients with persistent hyperplastic primary vitreous. Number one, small size of the globe. Number two, absence of calcium, which is better seen by CT, of course. A small irregular lens, shallow anterior chamber, and generalized increased density of the vitreous, either in the CT and MRI, intravitreal shadows, and sometimes fluid level if there is a subretinal hemorrhage, as in this particular case. And this is also another example. The first, you see that the globe is small and is bright in all pulse sequences, and the lens may be deformed with some intravitreal shadows. This should be discriminated from the dangerous lesion which occur also in the pediatric age group, which is the retinoblastoma. In retinoblastoma, the main diagnostic clue is the presence of calcium inside the mass, inside the globe, and leukocoria of the pupil. Then MRI is not sensitive for detection of calcium, but whenever you see a mass inside the globe and this particular age group, you should think of a retinoblastoma. And you should know that retinoblastoma cannot be biopsied before surgery. So if you diagnose retinoblastoma, meaning that this eye will be removed, then you should be careful about the diagnosis of retinoblastoma in order not to be mistaken for other lesions that can occur in the globe of the child. The next case is an MRI of the orbit post-contrast fat T1 weighted image. No, this is not optic neuritis. Optic neuritis means that the optic nerve itself is enhancing. Okay, and if you look carefully here and you see that the optic nerve sheath is enhancing, and you see that the optic nerve is going through the enhancing sheath, which is diagnostic of optic nerve meningioma. This is right. Optic nerve meningioma can be just linear enhancement of the meningeal covering of the optic nerve, but you can see the optic nerve fibers going through the tumor, which is known as the radiolucent track sign. This is one of the pathognomonic features of meningioma in the orbit, and you got the tumor mass where the optic nerve is seen as a hypodense linear structure going through the enhancing mass. And this meningioma represents about 5% of orbital tumors and represents about 30% of optic nerve tumors commonly seen in females, as any meningioma elsewhere in the body, and may be seen in the children with neurofibromatosis. And if you look carefully for the orbit, you see what's known as the lucent track sign, where you can identify the fibers of the optic nerve going through an enhancing mass surrounding the optic nerve. And this is not the case in cases of optic nerve glioma. Optic nerve glioma involves the optic nerve fibers, and the tumor is globally may enhance. But meningioma involves the meninges covering the optic nerve, and the optic nerve itself can be clearly identified running through the mass. The next case is a case of MRI of the paranasal sinuses with a patient with facial pain, headache, nasal stiffness, and discharge. This is MRI T2, and this is diffusion with, I think this is a stir image, and this is ADC. And mucocele needs some expansion of the sinus, but is slightly or more or less similar to the opposite one. Okay, and then this is fungal sinusitis, right? The answer is good. If you look here in the T2 weighted image, you see obliteration of the right maxillary antrum by secretions. And these secretions are black. Some of the secretions are black in the T2 weighted image with diffusion restriction. And this is one of the criteria of fungal sinusitis is that the intrasinus secretions are of dark signal in the T2 weighted image. Also on the CT scan, you can see that the fungus is of hyperdense attenuation value compared to the secretions of ordinary sinusitis. And this is one of the ways to identify fungus on top of sinusitis. If you can see hyperdensities inside the sinus, even without intravenous contrast injection, these hyperdensities are seen in the pre-contrast study. Then if you see that the antrum is expanded, you may also diagnose mucocele. And these mucoceles, because of the long-standing condition, may be infected by fungus. Then in order to diagnose fungus, you should look for the T2 weighted images. And you can see that fungus is very dark on the T2 weighted images. And on the T1 weighted images, the fungus is a little bit dense, as you can see, compared to the secretions of usual sinusitis. On CT scan, two main findings. Number one, hyperdensities, and number two, calcification. And this is a good example of fungal sinusitis. The next case is an MRI T1 flare, T2 with contrast, T1 with contrast axial, and coronal with contrast. Right, and the answer is olfactory neuroblastoma or isizino neuroblastoma. The answer is right. This is a malignant lesion arises from or centered to the region of the cribriform plate of ethmoids, and it has a component in the ethmoidal air cells and another intracranial component. Many times it can be mistaken or included in the differential diagnosis of lesions occur in the anterior cranial fossa. But this lesion is an aggressive one, and it usually extends inside the orbits as well as intracranially, and it may give distant metastasis in about 20% of the cases, and is hypervascular and may bleed on biopsy. These are the criteria of the neuroblastoma, which is a dumbbell-shaped mass, partly intracranial, partly extracranial. The upper portion inside the cranial cavity, the lower one is in the ethmoidal air cells. The waist is at the cribriform plate or the floor of the anterior cranial fossa. Calcifications are present, And this cyst formation at the brain interface is considered by some as one of the pathognomonic features. You may see it's not seen in this case. You may see some cystic lesions at the interface between the tumor and the brain tissue. Then it may show homogeneous or heterogeneous post-contrast enhancement and metastasis as we have mentioned. And this is another example. And you see that there is a big lesion in the ethmoidal air cells invading the orbit. And you can see that part of the lesion is inside the cranial cavity. Then any one of you may ask why I should not say that this is an ethmoidal carcinoma invading the orbit and intracranially extended. You are right. And this should be one of the differential diagnoses of this mass in this particular area. Number one, you say that this is a neuroblastoma or olfactory groove neuroblastoma, squamous cell carcinoma of the nasal cavity or the ethmoidal air cells, lymphoma, and metastasis. All should be included in the differential diagnosis of this mass, which is usually diagnosed by biopsy. Next case is an MRI of the orbit axial T2. Rhabdomyosarcoma. I said in the lecture that of course this is a child, and if you look to a child orbit and you got a very big mass, yes, the answer is retinoblastoma. Yes, is right. If you see a big mass and you cannot see the globe, whether this globe is removed surgically or not, and you consider it as a retinoblastoma, because if the globe is removed, it will be removed for retinoblastoma, and this is recurrence. If the globe is not removed and is included in the mass, then you know that the mass is arising from the globe and is also retinoblastoma. Then in such a case, the globe has been removed surgically for retinoblastoma, and this considered the recurrence of the retinoblastoma itself. This what I have said in the literature. If you see a big mass in the orbit of a child and you cannot see the globe, whether this globe is removed or not removed surgically, then you consider the possibility of retinoblastoma. These masses also occur in the pediatric orbit, and they are big, but you can see the globe, such as lymphangioma, capillary hemangioma, hemangiopericytoma, rhabdomyosarcoma, and plexiform neurofibroma. The next case is a female patient, 41 years old, with redness, pain, decreased visual acuity in the left eye. The patient had undergone an unrelated bone marrow transplant 7 months prior. Melanoma? No. There is no mass inside the globe. What are you seeing here is just debris inside the globe, which is partially collapsed. No, this is not an orbital pseudotumor. Does not affect the globe too much. It affects only the sclera and the orbital fat, sometimes one of the extraocular muscles, and the lacrimal gland. And cellulitis, orbital cellulitis, for the diagnosis of orbital cellulitis, there should be ethmoidal sinusitis. There is no orbital cellulitis without ethmoidal sinusitis. Because the infection extending from the ethmoidal air cells into the orbit, this orbital infection at that time is known as orbital cellulitis. But this is an inflammation involving the globe as well as the orbital fat with some enhancement as well as a swelling of the eyelid, and this is known as panophthalmitis. Panophthalmitis meaning that the globe and the orbital contents are inflamed. But ophthalmitis means that only the globe is inflamed. Orbital cellulitis means that there is ethmoidal sinusitis that has extended inside the orbit through the infected ethmoidal air cells. And because of the bone marrow transplant, the patient immunity is bad, of course, because she is receiving immunosuppressive drugs, and this may help to infect any part of the body. And in such case, you got panophthalmitis. Panophthalmitis means that the globe has been transformed into an abscess and the lens is distorted or even not seen in the scan with heterogeneous appearance of the fat and the hazy appearance of the orbital sclera. Then the muscles may enhance as well, and the fat is also dirty. And this is also another example. You got what is known as physis bulbi, where the globe is totally collapsed and calcified. You may call it end stage globe. You may call it like end stage kidney, for example. And this globe is collapsed and calcified, the end of panophthalmitis. And this is not this is the appearance of orbital cellulitis where you got there should be ethmoidal sinusitis and the orbit on the same side of ethmoidal inflammation is inflamed as well. You got very swollen eyelid and you got enlargement of the lacrimal gland. You may got subperiosteal abscess and dirty appearance of the fat. This is orbital cellulitis. Then the next case is similar to the cases presented in the exam. Then you got a section in the neck with some provided answers, and he said some said that this is vocal cord paralysis, and the others said that this is internal laryngeal. Both are not right. Actually, this is the epiglottic fold, which is markedly thickened compared to the rest, and the right answer is laryngeal cancer. Is a supraglottic laryngeal carcinoma that affected the epiglottic fold on the right and the left side, and you can compare it to the epiglottic fold on the right side. I presented new lectures in the larynx and I corrected one of the informations that I have said that the supraglottic cancer is the most common, which is not right. The glottic cancer is the most common, representing about 65% of laryngeal cancer, followed by supraglottic, and the last is the infraglottic. The glottic cancer occurs in the region of the true vocal cord. Anything above the level of the true vocal cord is considered supraglottic. Anything below the true vocal cord is considered subglottic. And you know that the laryngeal cancer have intimate relation to smoking and alcohol consumption. Of course, they are major risk factors for laryngeal cancer. And most of the laryngeal cancers are of the squamous cell type, and they frequently seen in old age, but because of the very common nowadays, the smoking habits are going spreading fast through the young generations, then you may got younger people with laryngeal cancer and also bronchogenic carcinoma, as I see in the clinical practice. The important findings for laryngeal cancer is to mention some of the facts, and these facts include, you mentioned something about the anterior commissure and something about the posterior commissure. These should be included in the report if they are infiltrated by cancer or not. Then you should say if the cancer has extended above or below the level, if it has invaded the laryngeal cartilage or not, if it is associated with metastatic lymphadenopathy or not. This is an example of laryngeal cancer, which is affecting the. You should not say that this is the glottic area unless you see the arytenoid cartilage. The arytenoid cartilage, which is fixing the posterior aspect of the vocal cord, the true vocal cord. And if you see this arytenoid cartilage, you may say that you are dealing with a glottic cancer. If not, this will be of the uh, above the level of the true vocal cord, considered as supraglottic carcinoma. This is a male child, 3 years old. This is the initial scan, and this is the follow-up scan. Optic nerve glioma. Which one? In the follow-up scan or in the previous scan? The follow-up scan. Then what do you think that this patient had no optic nerve glioma, and in the follow-up scan developed the optic nerve glioma? Okay. Let us concentrate on the pre-initial scan. You see an intraocular mass, and this mass contains calcium, and this is diagnostic of retinoblastoma. And retinoblastoma is treated by inoculation. And inoculation usually is replaced by an artificial globe. In the follow-up scan, you got a mass inside the orbit, meaning that the retinoblastoma has recurred. And this is the condition. The child has a retinoblastoma and surgically removed. On the follow-up scan, you got recurrent lesion in the posterior aspect of the orbital cavity. Retinoblastoma, there's a lesion that occurs inside the globe of the pediatric patients, and it can be bilateral in about 30% of the cases. The main pathognomonic feature is calcium, and whenever you diagnose retinoblastoma in an eye, you should look carefully for another retinoblastoma in the opposite eye because of the high frequency of bilaterality. MRI is weak in detection of calcium, but it can detect the mass. And whenever you see a mass inside the globe of a child, you should think of retinoblastoma. Next case is a female patient, 73 years old, with progressive painless supraorbital soft tissue mass with gradual diminution of vision in the right eye and the nasal discharge. Yes, the answer is right, and this is the mucocele. Mucosal of the ethmoidal air cells, there is marked expansion of the ethmoidal air cells with encroachment on the orbital cavities with displacement of the globe, and this is diagnostic of a mucosal. The mucosal is diagnosed by the presence of an expanding opaque one of the paranasal sinuses or part of the paranasal sinuses, like this one, where you got a mucosal in the posterior ethmoidal air cells. And this mucosal, because of the mucus content, it may appear of high signal in the T1 weighted image and also of high signal in the T2 weighted images. If you inject a contrast, the mucosal will behave like an abscess and it will show marginal enhancement. Mucosals are frequently superinfected by fungi, and at that time, if you look in the T2 weighted image, you see the dark signal of the fungus. Mucosals, of course, result from obstruction of the drainage of the sinus, which may be due to chronic sinusitis, trauma, or surgery, or benign or malignant lesions. And this is an example of maxillary sinus mucosal, which is not the most common in the paranasal sinuses. The common one is seen in the phrygmoethmoidal area. And intrasinus hyperdensity may stimulate the diagnosis of fungal infection. Hyperintense on both T1 and T2 weighted images may result from the mucus content of the mucosal. Then this is the other case, and is CT of the larynx, coronal reconstructed images and image and the two axial images. Then what do you think? Okay, one of the policies whenever you are going to interpret images of the larynx, if you have the coronal images, they are of great help because you are able to look for the look on the healthy side. This is the true vocal cord, and this is the laryngeal ventricle, and this is the false vocal cord. This region is totally obliterated by this enhancing mass, which is seen here in the axial images, and you can see marked enlargement of the area epiglottic fold with deviation of the fold medially and the consequent widening of the piriform sinus. All these signs are considered signs of vocal cord paralysis, which should not be mistaken for laryngeal cancer. These are the signs, all the signs of vocal cord paralysis. Number one is dilatation of the laryngeal ventricle. You see here the ventricle is dilated compared to the opposite one, which is obliterated. Loss of the subglottic arch in this situation, you may sometimes got the medial deviation of the posterior vocal cord. This is the vocal cord identified by the arytenoid cartilage, and the cord is deviated medially. Then anterior positioning of the arytenoid cartilage compared to this one, it's a little bit shifted anteriorly. then enlargement of the pyriform sinus compared to the opposite one, then mushroom sign, which is tilting towards the left side. And you see that the larynx, and you got some of the tilt on the left side, and also you got this step-like deformity at the level of the laryngeal ventricle. These are the signs of vocal cord paralysis, and you may also realize that there is no an enhancing mass, and this is just the epiglottic fold containing fat. There is no laryngeal mass. Also, there is no laryngeal mass here. And these are the signs of vocal cord paralysis, not to be mistaken for laryngeal cancer. In this example, you got a female patient with 2 months history of hoarseness of voice and left otalgia. Prior to admission twice for laryngitis, but her complaint did not improve. And this is glottic actually. If you see the arytenoid cartilage, then you know that the tumor is in the true vocal cord. And this is glottic cancer occurring in the region of the true vocal cord. Of course, if you are asked about the differential diagnosis, as I have mentioned, in all parts of the head and neck, you mentioned the three possibilities. You mentioned the primary lesion that occur in this particular area, which is carcinoma. Then if you are asked about the differential, you say lymphoma and metastasis. Then this tumor should be diagnosed as laryngeal cancer. If it proved by biopsy to be a lymphoma, there is no sign to diagnose lymphoma of the larynx unless you have bilateral submucosal lesions, as I will mention. But if the patient had a primary malignancy, you consider metastasis. If not, then the diagnosis will be laryngeal cancer. Laryngeal lymphoma is rare, and it represents about less than 1%, occurs in old age, and the supraglottic area is more common than the glottic involvement. Laryngeal lymphoma presents clinically and radiologically similar to squamous cell carcinoma. And laryngeal lymphoma is diagnosed by number one, large submucosal component. Number two, frequently in the supraglottic area. This is very important, is multiple lesions. Multiple lesions strongly suggest the diagnosis of non-Hodgkin lymphoma. I mean by multiple lesions, you got a lesion on the left and another one on the right, which is not the case for laryngeal cancer. The next case is an orbital CT. Okay, there is some error in the internet, but I hope it's good now. Um, what do you think about this orbital lesion? You don't see the images yet? Okay. The internet connection is not stable. Okay, let us go back, and if you see the CT scans now, Okay, the laryngeal lymphoma. No, you do not see. Okay, all right. No orbital CT. I don't know the cause, but طيب. Can you see it now? Okay, you see the orbital scans, and the policy for interpreting the orbit is to locate the lesion in one of the well-known anatomic regions, which are the globe, the optic nerve, the lacrimal gland, and the extraocular muscles. If not, consider it within the fat. And this lesion is apparently in the lacrimal gland. Then you look if this lesion is unilateral or bilateral. If it is unilateral, then you consider the possibility of inflammation or neoplasm. Then inflammation like dacryoadenitis, sarcoid, neoplasm like carcinoma, lymphoma, and metastasis. The signs of inflammation is marginal enhancement, the dirty appearance of the surrounding fat, and the edematous changes of the adjacent soft tissue structures. If not, you may consider that this is a lacrimal gland mass, and the diagnosis include inflammatory and neoplastic, and you say what possibilities of inflammation and what possibilities of neoplasm. And this is, of course, an inflammatory lesion with marginal enhancement and perilesional fat stranding. Lacrimal pseudotumor is also one of the inflammatory lesions of the lacrimal gland. It affects the orbital fat and also the outer coat of the globe, the lacrimal gland, and the eyelid. And if the lacrimal gland is only involved, you got this dacryoadenitis with intraglandular abscesses, as you can see, edematous changes of the skin anterior and lateral to the orbital cavity. This can help you to spot that this is an inflammatory lesion. In this case, the answer is already projected, and you got bilateral masses in the globe, diagnostic of retinoblastoma, and another mass in the pineal body. And this is in the literature is known as trilateral retinoblastoma. Sometimes you may got also another mass in the suprasellar area, then it's known as quadrilateral retinoblastoma. Then unilateral, bilateral, trilateral, quadrilateral. The trilateral retinoblastoma is a hereditary form of retinoblastoma. It may occur in about 30% of the cases, and this is bilateral ocular retinoblastoma and the primitive neuroectodermal tumor. This primitive neuroectodermal tumor may arise in the pineal body region or in the suprasellar area. Trilateral retinoblastoma represents about 30% of patients with retinoblastoma. Then this is the case of female patient, 31 years old, with bilateral proptosis. Okay, there's still trilateral retinoblastoma. Yes, there are some problems in the internet. And what do you think? Okay. Orbital neurofibromatosis or Graves' disease. Graves' disease, meaning that the extraocular muscles are enlarged, but this is not the case. There are multiple lesions inside the globes, and these multiple lesions are enhancing and they are solid. Then you consider lymphoma, neurofibroma, metastasis, and vascular malformation. And if you know that this patient had the neurofibromatosis type 1, then you know that this is neurofibromatosis of the orbit. And you remember the differential diagnosis I provided before. Whenever you see homogeneously enhanced lesions inside the orbit, consider cavernous hemangioma if it's a solitary lesion, neurofibroma or neurofibromatosis, and consider also the lymphoma. Then this is orbital lymphoma, where you got large masses, and these masses are characteristically encasing the globes. And this is one of the pathognomonic features of lymphoma, which is usually occurring after the middle age. And sometimes you got evidences of lymphoma in other parts of the body or in the history of the patient. And you got homogeneously enhanced masses with tendency to coat the globe, meaning that the masses has have the tendency to surround the globe. Then when to consider that lymphoma is the most likely diagnosis if you see an orbital mass? Number one, if you know that the patient has lymphoma. Number two, middle-aged patient with multiple solid enhancing masses. Number three, lesions encasing or coating the globe. Number four, multiple well-defined homogeneous enhancing masses. Number five is muscle affection, especially in particular, according to the literature, the levator rectus complex, meaning that the muscle in the superior aspect of the orbit, if it is involved, you may think of lymphoma. And if you see this images, and these are for a male patient, 60 years old, with nasal obstruction and epistaxis, and CT axial and the coronal MRI T2 weighted images. Do you see the images or not yet? No? Oh. Yes, you see the images, then what do you think? Nasopharyngeal carcinoma? No. And the tumor is centered on the maxillary sinus, and This tumor has destroyed the sinus walls, as you can see, and also yes, and this is maxillary carcinoma, of course, with the extension into the nasal cavity and the nasopharynx and also in the cheek. Destructive lesion centered over one of the sinuses, you consider the possibility of sinus carcinoma. And if you are asked about the nature of this carcinoma, you say squamous cell carcinoma, which is the most common carcinoma in the head and neck. This carcinoma is easily differentiated from a mucocele of the sinus, for example, or antroquanal polyp or inverted papilloma. All these lesions do not cause too much destruction of the maxillary of the sinus wall. And here you can see a destructive mass in the maxillary sinus that has eroded the sinus floor and the hard palate, with extension into the oral cavity as well as in the infratemporal fossa. Maxillary, the tumors are common in the maxillary antrum, followed by the ethmoidal hair cells, and finally by the nasal fossa. The symptoms are similar to sinusitis, but you may got some bleeding or blood-stained nasal discharge. And these are the CT findings of malignancy. Number one, soft tissue mass inside the affected sinus, homogeneous or heterogeneous enhancement, bone erosions or destruction of the affected sinus, and extra sinus extension into the surroundings. هذا وبالله التوفيق.